Okay, thank you. Hello. I'm the Max room. Good evening, students. So today we'll have a interesting case discussion, and Dr. Sudhir has to join. Before he joins, a bit of introduction about the case. One of the exam cases which you're going to get, and Dr. Srihari is going to present the symptoms, signs, investigations, and we'll have discussion about after symptoms, signs, and investigations. Then finally differential diagnosis. So you make your clinical diagnosis and prioritize what is the functional diagnosis at the end of the history, what is the anatomical diagnosis, what are the physiological traction, and what is the path pathological or etiological diagnosis based on history without examining the patient. With these few words, I think I'll ask Srihari to share the screen and start your presentation.
Good evening, sir.
Good evening. Yeah,
Shall I start?
you can start and right. Go slow so that all participants are slowly going to join.
Yes, sir.
Okay. Mm.
So today I'm presenting a case of a 12-year-old boy who's a right-handed individual, a sixth grade student, resident of Pune, Hindu by religion, and history was given by himself, which was reliable. He presented with the chief complaints of weakness in his left hand since 2 years, followed by weakness in the left leg since 10 months, and loss of temperature sensation in both hands since 1 month, and weakness in the right leg since 10 days.
Is studying the student or
Yes, sir.
school
Sixth
go?
standard. School. He's going in schools.
Okay.
So coming to the history of present illness, my patient was alright 2 years ago when he developed weakness in the left hand. It was insidious in onset and gradually progressive weakness. Initially, he says he used to have difficulty while playing games. He faced difficulty holding rackets and bats while playing, and also while trying to lift heavy objects with his left hand, and also doing fine acts like buttoning and unbuttoning his clothes. Over the next 1 year, he noticed difficulty holding smaller objects like the glass and holding a spoon while eating. He also noticed thinning of his left arm and palm, and also gave history of dropping his toothbrush about 3 to 4 times while brushing in the early morning. There were no associated muscle twitches or cramps.
So just wait and go back to the previous slide and re-emphasize the chief complaints.
So
Is a
first,
12-year-old boy is studying in which class?
six standards.
Sixth standard. Okay. And he developed
He
weakness in the left hand of 2 years, left leg of 10 months. And there are
lost.
some sensory disturbances in both hands since 1 month. So weakness in the right leg since 10 days. So as we always say, you have to mention the onset, which you feel is insidious.
Yes,
And
sir.
the progression is, the
Slow.
course is progressive.
Yes, sir.
You have to give this idea before you go into further. So you have to say it's a progressive, slowly progressive course for the last 2 years. Okay. And what
Yes.
are the salient points in this slide?
So mainly, initially, he had problems with dexterity with his left hand,
Hmm.
but it was his left hand, so he didn't give much attention to it.
Hmm.
But he noticed that he had difficulty mainly while playing cricket. He had difficulty holding the bat and also buttoning, unbuttoning his clothes. He had difficulty, and over the next 1 year, he had difficulty while holding a glass or spoon also while eating, and he also noticed some thinning in his arm and palm. There were no muscle twitches or cramps that he felt.
Mostly these are motor things.
Yes, sir.
Right?
Note.
Motor. And anybody wants to ask any question at this stage? Otherwise, we'll go ahead and go to the next slide. You can Q&A, you can ask the chat box. Otherwise, we'll go ahead. Okay.
So the weakness then progressed to involve his left leg. This is after about 1 year when he felt difficulty while climbing stairs and walking downhill. He says that on trying to bear weight on the left leg, he felt weakness and started holding the railing to support himself.
What are the activities of his? Is a active boy at this stage? Was he playing games and?
Yes, sir.
Uh,
So mainly he faced difficulty. He said that when he played Coco, he fell multiple times, and he had difficulty while running at school. And he says he used to lose balance, but he said he used to trip and fall towards the left side after running a few steps.
Okay.
But he never had any difficulty getting up from squatting position or any history of buckling of his knees. And he never felt that his legs were loose or weak. And he continued to indulge in sports despite his episodes of trivial falls.
So in this whole episode, what type of weakness you are conveying?
So he's having a progressive weakness initially left upper limb, then going on to the left lower limb. And it was gradually progressive type of weakness.
And could you give any indication that which part of the neuroaxis is involved in this?
Sir, I felt that it is most likely to be spinal cord. Whether it was a
No,
cervical.
when we decide about whether it is LMN weakness or UMN weakness first. So did you give any points towards that?
So he never gave any history of looseness of the limbs. So and he had falls after a few steps. So whether it was UMN type of weakness is what I thought.
So what are the points which will tell you that it's a UMN weakness?
So for UMN weakness, usually they will be having spasticity. In LMN, they will be having.
So patients won't say I have spasticity. So what will you ask? So like you have to ask me, you have to elicit. Something you have said.
Any looseness or stiffness.
Stiffness. So did he have any stiffness?
Actually, he didn't give any complaints of stiffness. But I asked him whether he felt looseness, and he said no.
Does he give wasting history also?
So he gave history of wasting, but not very significant. He just said that he noticed some wasting in his palms.
In the palms.
Yes.
Okay. So when wasting is there, what will you ask subsequent questions?
Any fasciculations, any involuntary?
Fasciculations. So any involuntary movements?
No, sir. He didn't have any fasciculations.
Okay. So are you conveying that there is a LMN lesion there?
I think it is like long-standing. Over 2 years, maybe he has developed the wasting. So
we should be clear in what you are conveying in exam. Because you have seen the case, you have examined, you made. So you have to make a convincing message that what I am hinting is, and I am trying to tell you that there is a LMN weakness. Also in the legs, there is a UMN weakness, right? So that point should be clearly brought out. Okay, next, go ahead.
So one more thing. Means are we clear whether it is proximal or distal weakness?
Yeah, he said it's clear. No, he has mentioned that there is no difficulty in getting up from squatting position.
But he said climbing stairs he has some difficulty.
Is difficulty. The climbing
stairs was mainly he was falling towards the left side, so not difficulty climbing stairs as such. Because of the fall and that sway towards the left, he had difficulty, so he had to hold on to the railing. That is the history.
But why is he swaying? Means swaying is a totally different symptom.
Not swaying, sir. He is losing balance sort of, and he's falling towards the side.
So suddenly he's giving up.
Yeah.
Right? With normal power, suddenly he's tripping.
Yes.
Knee buckling or something like that.
Sir, knee buckling should be because of this thing, quadriceps weakness, no?
Yeah, because there is a possibility that he has difficulty in fine tasks in the hand. So there is no wrist drop or foot drop as per the weakness. Then it becomes most probably because the fine tasks are involved. It is a UMN type of picture. So he may be having small amount of spasticity, which is making him buckle. That's what I could infer from this.
Yes.
Anybody else wants to say?
Shall I
You
go
are
ahead?
not, you are not clear. Clearly, you can type if you want.
Please others mute themselves because they will be disturbed.
Are you? You can continue.
So,
Yes, continue.
yes, sir. After this, so 2 months ago, before he came to us, there was he said that while climbing a tree and hanging onto a branch with his arms, he suddenly couldn't bear his body weight, and the branch, he gave away his left hand, and he had a fall from about 10 feet height.
Hmm.
He did not sustain any major injuries, and he continued with his daily activities. He didn't tell his parents also about the episode. And after the fall, he started experiencing neck pain, which he described as a sharp shooting pain that worsened on bending the neck forward and backwards. There was no any radiation to the arms, and he also said that the pain worsened whenever he coughed or whenever he bent his neck. And at times he said that he started to feel a shock-like sensation on his neck also.
So in this slide, what are the differences you are giving us? What are you trying to say?
So one thing is that he
He has
had a
been very
fall.
active. Despite all this, he's been active and climbing trees and things like that.
Yes,
That's
sir.
one point which is clear.
Yes, sir. He's
He
been
had a
very
fall.
active, and he had a fall from about 10 feet.
Hmm.
Mainly, I think, because of the progression of the weakness in the arms, distal arms.
Okay.
And he did not sustain any injuries, but after that, he started saying that he also experienced neck pain.
So what is
And
this pain? Can you characterize further? Do you think that it is radicular pain or anything else? You can characterize it. Is it
yes,
musculoskeletal pain, local pain, suboccipital pain,
so
neck
it
pain?
was, yeah, it started in the suboccipital region, and it was there throughout the neck. And he described it like a very sharp shooting type of pain, and also a shock-like sensation that he felt on his neck.
So, what are you trying to convey towards its shock-like sensation? Are you saying that it's a type of lermit?
So it possible that it is a lumbar
Hmm.
sign, but it didn't go all along the
So, now
spine.
what I'm trying to say is you tailor your presentation so that there is no confusion in anybody's mind.
Yes, sir.
You can, if you are able to answer that, yes, I'm trying to say it's a lermit sign, we accept it. If you yourself are not able to clarify what is that, then there will be a problem. What I'm trying to say this neck pain. So whether it is musculoskeletal pain, so you should characterize it typically. It is localized to only upper cervical region. There is a constant pain punctuated by with movement, some shooting type of pain is occurring,
Yes,
right,
sir.
which is not radiating towards the dermatomes.
No, sir.
So then there is a chance that we understand that oh, it's only a local musculoskeletal. And now you shock like sensation. What do you want to convey with this?
So whether it was Lermit's sign,
So you say that no, you wanted to convey that there is a possibility of lermits.
Lermit's, yes.
Now, why lermits phenomenon? What is a lermits phenomena due to? How
So due to
when
posterior
will
column,
posterior columns? So you are thinking the posterior columns are involved. Lermits when you bring that means spinal cord involvement. You are suggesting to us. Okay, carry on with next.
yes. 1 week later, he complained of inability to feel hot water in both his hands. While bathing, he was able to feel hot and cold water in his feet and also on his face, but he could not perceive them in his hands. He could feel the clothes over his body and blanket over his legs while sleeping. He could perceive the slippers on his feet and also feel stones under his foot while walking bare feet. There was no complaints of any numbness, pins, or needle-like sensation over the hands or arms, and no slipping of slippers. And this was also associated with worsening weakness, and now he developed severe gait instability, and he started losing balance to both sides. Now he was falling towards the right side also.
So when he is still walking but with imbalance.
Yes, sir.
So
Like
one thing.
after few steps, he loses balance to either to the right or to the left.
Okay. So what are we looking at this? Inability to feel hot water in both hands. What does it tell? Anybody can answer this
That
question.
is
Other students, what does it tell you?
Loss of temperature sensation.
Temperature sensation. But why in both hands temperature sensation is last means where are you thinking the probable location of this problem?
Small fiber involvement.
Somebody said it is spinothalamic tract. Okay. Then what is the lamination and why are we discussing this? And what do you think?
it was
Depending
suspended sensory loss.
Could be, or it is a
Cape-like.
spinothalamic tract around cervical region where it is
Yes.
possible, isn't it?
Yes.
Because the lamination is from the medial to
Yes.
lateral. So whatever it is, it's the medial side of the spinal cord, that too in the
Cervical region.
cervical region possibly. The crossing spinothalamic fiber, somebody is saying that is a second order neuron. Second order neuron goes up and then it crosses at thalamus to become third order neuron. They already crossed. And both hands are showing this problem. That means both hands are the cervical fibers are the innermost in spinal cord and the sacral fibers are outmost. So whatever he's saying that there's a problem in the cervical cord. Okay. Central lesion, that's very good. Right.
There was no history of any loss of consciousness, headache, vomiting, or
Sir,
seizure.
before we go further,
Yes.
can we go back to the previous slide?
Yeah.
As we said, there is mostly distal involvement, but then there is no slippage of slippers. Then how can we say it is distal weakness?
The hands
it is more like gait
correct.
instability.
There is a, it's not just a very smoldering illness. No, it's not a very manifest illness. He is a growing child, so he's able to compensate most of the weaknesses with his growth and strength so far. Because it's an insidious process that's happening. So if at all it is a problem in dorsal cord, the progression of the symptoms will be very fast. So it's not in
So,
the
but this last line, if you read this last line, especially this was with worsening weakness, and now he developed severe gait instability and started losing balance. So, are these two statements not contradictory? Means one way we are saying there is smoldering weakness, and they're saying worsening weakness.
That's one excellent point. That's why I keep telling we should not use statements like worsening weakness. We should say what are the acts which he could not do now. That will give you an idea. Then already inferring that he's got worsening weakness. When you say worsening weakness, you have to say earlier he used to pedal a cycle and go. Now he's not able to pedal. Then you get an idea that is worsening. So it can be subjective also. So this statement is as such is wrong. You have to say why you think it is worsening.
Yes, the symptom that worsened with in his case was that he started falling towards the right side also after taking a
That could be because of cerebellar tract disturbances, cerebellar hemisphere disturbances. There could be many other reasons. Why are you think it's worsening of weakness?
Yes, I thought now the right lower limb is also involved. Like
right lower limb is what is the involvement of right lower limb? What he was not able to do? Why do you think it is involved? See, he can veer either side if there are any cerebellar dysfunction are there, tract features are there. So it's not somebody's point. It's not exactly weakness that is bothering him. It is imbalance.
Imbalance, yes.
Right. So I think you have to change this sentence and you have to explain. All the students, what I want to say is you cannot give this inferences in your history. You can only say that what he is able to do and what he is not able to do. If you say progression is there, you have to say what task earlier he was able to do, now he is not able to do. And that's how you have to build up your story.
Yes.
So the gait instability. Yes.
Second point, sir, if the gait instability and imbalance means which is coloring this picture is too much, then even the presenting complaint, it should be like gait ataxia, not weakness.
Presenting complaint in patient's terms, gait instability, not ataxia. That we can bring it later.
Yeah.
To summarize, then you are saying correct. If you go back to the presenting complaints, Hari.
Yes.
So weakness in left hand. So that's what is the objectionable thing. But weakness in left hand, you said he has got difficulty in buttoning and things like that, dropping objects.
Yes, sir.
The left leg weakness, how did you
And
quantify?
so while walking, his left leg used to like he used to
That's
lose
what
his
exactly our students are saying. It's not a weakness.
weakness. Okay.
Weakness should be whether inability to wear slippers with awareness or without awareness, difficulty in climbing stairs, difficulty in no, if he loses speed while walking, or is able to run earlier and not able to run now because of
He was
some
not
reason.
able to run. So yeah, he
So you
started
have to
falling.
quantify that's what you have to bring in so that the audiences are confused whether you are talking about weakness or you are talking about gait instability. What do you think it has got predominantly?
Weakness.
Weakness.
Weakness
Then
that has
yeah,
led to
weakness.
instability.
Then you have to qualify weakness and bring forth what are the indicators of weakness. Okay.
Yes.
So
He's
you
having gait instability in the lower limb because of the lower limb weakness, I thought, and left upper limb weakness is how it started.
so lower limb weakness not only gives instability. Instability is because of proprioceptive disturbances, isn't it?
Yes.
It could be sensory ataxia or it could be cerebellar ataxia. We don't know. So if you are harping only on instability and this, then the whole thing is not totally weakness unless you get it in an examination.
Yes, sir.
So go next. Go to the next slide. Yes, next.
So there
So
was no
here,
history.
suggestion of any consciousness. I mean, cortical dysfunction features are not there.
No, sir. Even cranial nerve dysfunction, no history suggests of cranial nerve dysfunction.
Uh-huh.
There was no bowel or urinary disturbances.
Hmm.
No history of any sensory level in the body apart from the temperature loss.
Hmm.
And no profuse sweating, flushing over the body, palpitations, or any dryness of mouth experienced.
Hmm.
No tremulousness or any involuntary movements.
So anybody could localize this. So far, so many students are here.
Sir, once he says no bowel bladder disturbance or no sensory level, it will take away directly from the cord.
Okay. But then he has to explain
And
why the there is both the hands are having some temperature disturbance. That is a very subtle finding, no? So if somebody suggests a
sir,
central lesion,
it could be due to all sensory involvement because small fiber involvement can lead to temperature changes and then proprioception because he's saying mostly ataxia. So could it be all sensory predominant kind of neuropathy?
problem is upper limb onset. You are telling, sir, it can be syringomyelia. So one would say, see, temperature sensation is last whenever there is a central cause because those are the fibers innermost. So whenever you suspect a central lesion, we always insist that you should do temperature sensation test very carefully. And that is a dissociative sensory loss. What is dissociative sensory loss? Because the second order neuron is crossing in front of the central canal, isn't it? And the central canal, as it goes up, the sacral fibers are placed outside and the cervical fibers are placed inside. So whenever there is a expanding lesion in the center, then the first thing that goes is temperature. That's why temperature testing, dissociate sensory, these are very important findings when you examine. We only have a clue here. So no history of any cranial nerve dysfunction. What cranial nerves you are interested?
So lower cranial nerves, if you're thinking in lines of
So
syringomyelia,
far we are
then
thinking of cervical, that's
cervical,
lower cranial nerves. What else?
then Horner syndrome, or
Mhm. What
then
else?
if cord is involved, then always we should look at the eye. If there
Somebody said
is
trigeminal. Why are you not thinking of trigeminal? How trigeminal can get involved here?
like facial sensations,
Uh,
balaclava like loss.
So how trigeminal nucleus?
It
Where
goes
is
down
it
up to
located?
C2 and then it
So
rises up.
what
So
comes up to C2?
sensory fibers.
Spinal tract of trigeminal
Yes.
nerve nucleus. And the second order neurons will start there. after crossing, no?
Yes.
So it can come up to cervical cord, spinal tract C2, C3, that can happen. Horner syndrome can happen, right? All the lower cranial nerves can happen. Very good. And there are no autonomic nervous system disturbances here.
No, sir. No history of any autonomic nervous system disturbance.
Right. No involuntary movements. Okay, next.
No history of fever, weight loss, loss of appetite, night sweats, bony pains. No trauma to the head, no exposure to chemicals, no history of chest pain, breathlessness, abdominal pain, bony pains, cough, melena, hematochezia, altered bowel habits, or blood in urine. Past history, there's no history of tuberculosis or childhood asthma, no history of febrile seizures in childhood.
So, do you have any more history slides before the summary, or this is the last slide?
One more.
One more slide. Okay.
Developmental history is normal, and his age, growth, and development. He's doing well in sports at school. Family history is no similar history among family members. Born of non-consanguineous marriage, normal vaginal delivery conducted at home. Personal history: diet is mixed, appetite normal, sleep is adequate. That's it.
Somebody said small fiber neuropathy. Do you agree with them? Somebody says temperature is lost because small fiber neuropathy. What are the characteristic features of small fiber neuropathy? Small fiber neuropathy, how does it present? Whoever has asked this question can answer.
So usually small fiber neuropathies are painful.
Pain, burning pain, with normal
Yes.
sensory findings. Normal peripheral sensory snaps, sensory nerve action potentials. So a type of that pain is there, burning is there, but we are not able to characterize unless we do quantitative sensory testing and things like that. The stalking and cloud distribution is in a die-back phenomena that is observed in peripheral neuropathy. Both large fibers and small fibers are involved. The large fibers are mostly proprioceptive related. So if somebody says large fiber neuropathy, I can still agree because large fibers are fast conducting fibers which are correcting the posture. So they are likely to be involved in gait instability here. So it's not small fiber neuropathy. If at all you are thinking, it could be large fiber neuropathy because there is no burning pain in feet like you will see in Sjogren's syndrome and other features. Is it clear, or anybody wants to add anything more? So,
Sir, in this case, can I put a differential or later on?
no, you have to summarize now. I want you to summarize this case so far, whatever you think, and functionally, what does he have? Physiologically, what are the tracts that are involved in your mind? What are the anatomical location? Is it a diffuse location or is it single or multiple locations? And what possible etiology is there? By this time, because history is over, you should summarize and come to a conclusion. Neurology usually ends here. Examination is only cursory.
Shall I summarize?
Yeah. Who is going to summarize? Anybody from the audience, students? Before Srihari does.
Sir, as per the history, there is some weakness in the left upper limb. We started distally, and then some weakness in the leg, which is means really not very much on the history part otherwise. Looking like more of ataxia, and there are no sensory findings as such, means tingling, numbness. So I will keep it as mostly cerebellar ataxia, which started on one side first and went to the other side next.
So now you have to ask him,
So,
why didn't he tell any features of cerebellar attacks? He didn't say about smearing of face,
yeah.
not able to. You have to ask, no? When it is
Yeah.
crossing your mind, you have to ask him. Is it ipsilateral cerebellar hemisphere that is involved? Or what? Why do you think it is cerebellar? So that information has to give you. Okay. What else?
Yeah. So cerebellar means history should be more there about cerebellar function and speech also. And then what? And
How
there is some
account for the
temperature.
sensory disturbances, which is in both hands?
Yes, sir. So there is something which is involving some cerebellar tracts, some sensory tracts, these spinal thalamic tracts, and maybe some corticospinal tracts. So what I feel this area is around and he has some neck pain also, which is some shock-like sensation going down.
Hmm.
So probably some area around CV junction where, or the tonsillar herniation kind of, where multiple combinations can be there and they can have patchy involvement. They can have
So
smoldering
explain
pores.
patchy involvement of motor tracts in CV junction.
Yes, sir.
What
So
is lamination of corticospinal tract at the level of CV junction, cervicomedullary junction? What is lamination? The tracts which are coming down, they decussate.
yes,
Isn't
sir.
it? How so? How do you explain the patchy involvement? Can you get monoparesis or crossed hemiparesis in
Yes, sir. There
CV
is
junction?
Ellsberg phenomena,
Ellsberg.
which is usually seen,
Hmm.
uh, which is like one hand involvement, then leg, then contralateral leg, and then contralateral hand.
But is it a
So
complete Ellsberg here?
no, sir.
Hmm.
There can be, depending at the level of the involvement,
Hmm.
there can be means partial Ellsberg phenomena also
Hmm.
before the decussation, at the decussation, or after the decussation. So the
Okay.
levels may differ.
So that's one is Ellsberg phenomenon. At CV junction, one should know that there's a peculiar lamination of the corticospinal tracts. There is an anterior corticospinal tract, there is a lateral corticospinal tracts. The fibers of upper limb cross much above the fibers of the lower limb. So various combinations of weakness can occur, which may be very subtle till it manifests in later life, because it's not a thing which can, if you think CV junction can present second decade, third decade also slowly and insidiously. But obviously, many times it depends on whether it's a bony anomaly or a soft tissue anomaly. The bony anomalies may not present at all. People will go through their life with bony anomalies without having any problem. But if soft tissues are there, then the whole problem comes. So I think you are almost there. Anybody else wants to express anything? If not, then Hari, you can go ahead and summarize. Then they may have some other ideas.
Yes. So to summarize, we have a young boy with insidious onset and slowly progressive asymmetrical weakness, corticoparesis with wasting and gait instability, associated with loss of temperature in both the upper limbs and neck pain with no bowel bladder or autonomic features.
So
Functionally,
here they have where is the wasting you have noticed?
on left palm, sir.
So what is the root value of that?
So C8, T1, C8, C5 to C8, that area was wasted.
No,
Thenar,
you said left palm only, no?
left, so thenar, hypothenar, and arm, all three were wasted on examination.
So it is not C5. Where is C5 coming here?
No, C8.
So what is the root value of
C81.
C81? So you are having a C81 involvement, right?
Yes.
Or the thenar and hypothenar also C81.
C81. Even
So,
arm was wasted, and actually on examination, sir.
on examination will come later. Don't
Okay.
bring it. So far you have
So,
only.
but the thing is, because in CV junction problems, there can be venous congestion, and because of that, there can be means distal like CAT1 involvement, where the level is not CAT1, but because of the venous congestion,
Yeah.
the dermatome is affected.
That really is applicable to all sensory levels. Any sensory level, wherever it is, there is always you have to screen the whole neuraxis above that in the spinal cord.
Yes.
That is the dictum because of the lamination. So sensory level is not the hardest of all the localization features. So yes, you are correct. It could be because of that. And loss of temperature sensation, both upper limbs, neck pain. Any observations in this? So we are not agreeing, Hari, with your wasting. I mean, with your gait instability, weakness. Major problem is weakness, right? And nobody is agreeing with you about weakness, whether weakness is there or not, right?
This is Dr. Bhupesh. I'm the consultant here in Batra Hospital,
Yes,
Neurology.
yes. Oh, yeah.
So I was invited by one of our staff members only. So
Very
I would
nice.
like to comment
Welcome. Please.
Thank you. I would like to comment on this because the diagnoses are properly written out here. My key supporting points in syringomyelia is basically the dissociated sensory
Yes,
loss
yes,
here.
yes.
Asymmetrical quadriparesis with the wasting and the cervical involvement. The basically the gait stable instability and the cervical involvement is there. And absence of the bowel and bladder autonomic features are also involved here. So, I mean,
There are no
these are
autonomic
certain.
features.
Okay, so maybe I have read it wrong.
Yeah, there are no bowel bladder autonomic features.
Oh, no bowel. Okay, I read otherwise. Okay, so I mean, what I can feel here is the asymmetrical quadriparesis with wasting. That is one of the points that we can look into, and the other one can be dissociated sensory loss.
Sensory loss. That's true, and a slow,
Sir.
insidious process, which a child is very active. Still, he is even climbing trees and doing everything. That means whatever is smoldering is happening, but it's not very sinister thing that's happening so far in his life till he came to medical attention.
Sir, but in one question, in syringomyelia, will we have gait instability and why?
See, we are not only thinking of syringomyelia. Syringomyelia is one of the, it can be associated with the Arnold cherry malformation, various other spinal dysraphisms. So it is only at this stage we can only think that there is a dissociated sensory loss. So there may be a syrinx possibly, right? There is a neck pain that we have to explain. Could there be any cervical, craniovertebral junction anomalies there because the pain is in the neck? And also we know that there is posterior column involvement because there is a gait instability and alarmids. And whatever weakness he could brought out, that also is there. So all these things are coming close. So it's not only syringomyelia, there is something else also there. Right? You agree with me?
Yes, sir.
Syringomyelia is only one part. There may be others, no? Like it could be Arnold cherry malformation. We don't know.
The differentials that I can think of, sir, is the CVG anomaly. CVG
it's not only CVG anomaly, he has to quantify it. What is that anomaly? Is it a bony anomaly you're talking? Is it atlantoaxial dislocation? Did he cover the features which are supposed to be there? Like he didn't cover any features of vascular insufficiency if it is CV junction anomaly.
Yeah, there was no mention of Chiari malformation or basilar invagination. There was no mention of that. So I'm just talking from the differentials.
CVG anomaly he mentioned. That's okay. And all these things will come in that. But in history, you should have mentioned there is no drop attacks. Right? There is no vertigo. They say vertebrobasilar insufficiency features had to be brought out. Those were not
short neck also. Short neck.
Short neck, he may tell us in the findings, we don't know. But so far he hasn't told about the posture. So that is, suppose if it's a bony anomaly, as I say, if you look at the foramen magnum, it is divided into three portions. One portion is occupied by dens. The other portion is occupied by spinal cord. Still, there is one more portion which is vacant, right? The 1/3, 1/3, 1/3 rule. So that's about 19 millimeters to about 22, 23 millimeters is the total diameter there, the spinal cord. So you have a lot of space available. So that means this boy is having a problem. Mostly it is not in the soft tissues. That's why he's able to do so many things. This is one, so soft tissue along with bony anomaly. That's what is the mind, we think. So what you said, basilar invagination and all has to come into differential diagnosis on the common rubric of CVG anomaly. And CVG anomaly along with syringomyelia, all the students, if ACM is there, it will be given. So you should keep in mind that Arnold cherry malformation is very important, one of the diagnostic points which you have to mention. Can we go ahead, Dr. Bhupesh, or anybody wants to say something more, or we'll go to the findings? Okay, Hari.
Sir, can you just in brief means tell us how to means what are additional points to decide on which type of CV junction anomaly it is history wise?
CV junction most common presentation is suboccipital pain. Usually, historically, suboccipital pain and drop attacks. And these are then they can have monoparesis and diplegia, quadriplegia, slowly onset, not paresis. slowly onset. So these are the, and sensory levels can be there or cannot be there. They are very subtle findings. So most important is the drop attacks and suboccipital pain that will tell us, and of course posture, short neck. And if there's a history of tuberculosis, rheumatoid arthritis, and maybe some of achondroplasia, Paget's disease, all these things will have, that is secondary. But by birth, whatever happens, because of the embryology of the region, that will slowly manifest in second or third decade without these disorders. So that is very difficult to, unless you examine, you will not be able to pick up. So this is a 14-year-old boy, and he's very active. There is no cortical dysfunction features at all. He's has a growth, normal growth, and the only thing that is disturbing him is the subtle imbalance which has affected and made him fall. So that is a catch point here. So these 2 points I want to drive: suboccipital pain whenever you have, that's one, and second is drop attacks, and all these band, vertigo, ataxia, dysarthria, dysphagia. So these are the 4 cardinal features of vertebrobasilar insufficiency. The nystagmus, of course, on examination it may come. So that we can ascertain later. But these features are not inquired in this case and not given also. So one is bony, one is soft tissue, then is vascular. All the 3 components will be there for CV junction.
Okay, sir.
Okay, carry on.
Coming to examination, general physical examination, the patient is conscious, cooperative, oriented to time, place, and person. Pulse was 82 beats per minute, regular in rhythm. Blood pressure was 110 by 80 millimeters of mercury in the right brachial artery in supine position. Respiratory rate was 14 per minute. His height was 144 centimeters. Height neck ratio was 14.4. He had a short neck and posterior hairline was low line. He had no neurocutaneous markers, pallidus clubbing, cyanosis, lymphadenopathy, edema, no tuft of hair on the back, no dysmorphic facies or subcutaneous nodules on examination.
So what are the dysmorphic features? I mean, what are the spinal dysraphism markers on the body? Where all you can see?
So on the back, if you have a hairy nevus, tuft of hair on the spine, like in tethered cord syndrome,
Okay.
or any myelomeningocele, spina bifida, then neurofibromas.
Neurofibromas. Why?
Neurocutaneous.
I mean, that is one of the neurocutaneous markers.
Markers.
Okay.
Yes.
Okay. So there's no tuft of hair, there's no pilonidal sinus, there's no discharging sinus on the back.
No.
Okay. Next.
Neurological examination, sir. High mental function, speech and language were normal. Cranial nerves, intact smell sensation, visual acuity was bilateral 20 by 20 on both eyes. There was no papillary edema, no optic atrophies. Pupils are both equal in reacting to light. The cranial nerve examinations, there was no nystagmus, extraocular movements are normal.
What type of nystagmus you are looking for here?
Any downbeat nystagmus?
You should mention when you are, now you have to hit on the point which you are harping, that it could be CV junction. So I am looking for downbeat nystagmus.
Yes,
right?
There was no downbeat nystagmus, there was no Horner syndrome. Lower cranial nerves were normal, except that the neck flexion, there was pain. It was painful, and there was mild weakness on extension and flexion.
So just suppose if you are thinking of CV junction anomaly, so what are the movements that are happening at the atlantoaxial joint and also at the atlas and occipital region? Anybody can
There
tell?
are four movements: flexion, extension, lateral neck rotation, and neck rotation.
Okay.
So,
the anteroposterior movements are happening at what place?
Extension is at this atlantoaxial and occipito-atlantal.
Is it atlantoaxial? Atlantoaxial is
Rotation only at atlantoaxial.
Hmm.
Flexion and extension will occur at both occipito-atlantal and atlantoaxial.
But more of the occipito-atlantic class. So because that is the anteroposterior division movement, and rotation can happen, but to lesser extent. The moment that the rotation is about 20 degrees. not beyond that. Okay, so the movements, what did you say about the movements?
So he had painful neck flexion extension. It was weak, and but rotation was full and free.
The rotation is so you are
But
approaching
lateral
the
movement-
atlantoaxial joint.
Sir.
Yes, please. Somebody is saying something. SS movement, atlanto-occipital. Yes, that's correct. No movement, atlanto-axis. That's correct. So simply anteroposterior is atlanto-occipital joint. Okay. Tongue is normal with no deviation, no fasciculation, no atrophy.
Yes. So coming to the motor system, so there was significant wasting seen mainly in the left thenar, hypothenar areas, and there was also minimal wasting in the forearm and the left thigh. So left forearm was 10 centimeter and right was 12. Mid thigh left side was 25 and right 27 centimeter.
How are you going to explain left thigh wasting? So far in your this thing, you didn't think of any multiple lesions. How will you explain?
So cervical, like left, as Sir said, Ellsberg phenomenon, and then gradually started with left upper limb, then left lower limb also involved since 1 year almost, 1.5
You are
years.
talking about wasting. It is weakness there. That weakness is different.
Yes.
Wasting is a feature of radiculopathy or lower motor neuron, isn't it?
Yes.
That weakness, what is Ellsberg phenomenon is of UMN type of weakness.
UMN types.
So how will you explain left thigh? So maybe I think you'll have to recheck the findings, or you have to give explanation for it. Any explanation is possible?
So long-standing, whether it can lead to some
Disuser, he's not at all. He's walking, he's playing so well. He's climbing trees. It's possible if he's a bedridden or chair-bound, yes. Disuse wasting, but not here. Central lot can involve anti-horn cells also. That's correct. That means
Yes.
thinking of left thigh, which is L2, 3, 4. Shubham, you think that it is because of syrinx then?
What's that?
Central cord lesion can involve anti-horn cells also, but left thigh is wasted. How will you explain that? So that is a finding which is debatable, which in your mind, but we'll have to look at that. Unless there is a syrinx, which is a very long syrinx, is coming in the lower part of the spinal cord also. Then only you can explain that. Otherwise,
Sir, here
yeah.
So the difference between left and right is 2 centimeters in the lower limb. Isn't that acceptable?
It's acceptable. That's what I'm trying to say.
So
that's what the debate.
There is no wasting then.
So it is. So you can't, unless you are able to explain, because you have seen the case. No, I didn't see the case.
Yes.
They didn't see the case. So you should be able to explain how you are saying. And so that difference is acceptable, right?
Yes, sir.
Because you're not able to explain also mid thigh. But unless you have some point to tell us.
Yes.
Okay. Then
So tone. So the bilateral lower limb tone, there was spasticity in both lower limbs. And on examination of the power, there was a mild weakness on the left side in the upper shoulder flexion extension, abduction. Adduction was normal. Otherwise, elbow flexion extension was also 4, and on the left side, wrist flexion extension was 4, and the hand grip was 70% weaker on the approximately 70% weaker on the left side.
When he was walking, he's falling on either side, right and left?
Yes, so initially onto the left, and since the fall 2 months back, since then he's having on the after the fall.
Another important indicator in this examination is he's having strictly motor weakness on the left side, not on the right side. So whenever such thing comes in mind, you have to think of Brown-Sequard syndrome. So you have to carefully look for posterior column signs, proprioception on the left side, and spinothalamic sensations on the right side. There will be some, you may not get a clear-cut textbook picture, but what it suggests so far is like a Brown-Sequard in cervical region. Possibly, we don't know, we have to see.
Yes.
Okay. Next.
So lower limb, actually I got mild weakness in the left side also.
Knee extension.
Sir?
That's only thing you said is right side knee extension, but others are there. Right side, left side knee flexion is okay. Others are weak.
Weak, yes.
How do you explain knee extension weakness? What are the muscles acting for the extension?
For which one's a knee, sir?
Knee extension.
Quadriceps femoris is the main extensor.
What is and root
Femoral
values?
L234.
L234. So you are involving L234.
So it is there bilaterally whether now the lumbar
So now
laminations are
what
also
I'm trying
getting
to say
involved.
is, if subtle findings are there, when you see the whole case, certain things we have to just set aside. You don't have to
Okay.
bring them unless it is very important for you to knit up you have to knit up a story with no loopholes. Okay.
Yes.
I'm not going to see this, but it is striking that knee extension is big. How are we going to explain? The left thigh is wasted. How are we going to explain? So it's not fitting into your overall picture. Examiner has got no time. Examiner will go by what you say. He
Yes.
will check some findings. So subtle things which you are able to manage, just I don't think you should come out and express yourself, because overall comprehensive picture you have to take. Okay.
Yes.
Next.
So all his reflexes were brisk, and he had ankle clonus left side more than right, well
But your
sustained.
knee is 2 plus you are showing. That is not brisk.
Sorry, it was actually it's a typing error.
Uh-huh.
It is brisk. He had clonus actually. I'll show the video.
Ankle clonus is there. Okay.
Yes, and both plantars were extensor,
Hmm.
and he had both Hoffman and Wattenberg positive. There were no mirror movements. Abdominal reflex was seen. No cerebellar signs apart from the ataxia that is there. I'll show the video of his gait.
Hmm. Hmm. The abdominal reflexes are present here. How will you explain? You show the video first, then
Yes.
we can discuss. Which one you're on? Okay.
This was him getting up from squatting position and also from the floor. He's able to do it well.
Okay. Still there is a difficulty in getting up.
And so this is the clonus.
Okay. You have to lift the limb a bit up. Put your hand underneath the leg, not over the leg.
Yes.
Right?
Yes.
You have to put it underneath and lift it up and then do. You are able to demonstrate, but it will become much more better if you put your hand underneath the knee and allow
Yes.
the gastrocnemius and soleus to contract uninterrupted. You put in the hand where the muscles are there, no? Though you are able
Yes.
to elicit, it's okay. But next time once you don't do that. Okay.
This was the gait when we admitted him.
So there is the broad base gait and there is instability.
Yes.
Is there any foot drop or anything?
No, so there was no foot drop.
Mild weakness of the left ankle is visible. He is wearing on either side. Okay. So any observations from
Next
anybody?
this is him walking on toes.
Yeah.
He's able to walk on toes, and
Yes.
also after that he'll walk on his heels.
You're not able to walk on heels?
He is he was able to, sir, actually. The video cut gets over here.
So that doesn't help us, no? If you are able to demonstrate one or other, you can get some localization value in that. Whether it is spinal cord or whether peripheral nerve is obvious. Whenever there is a foot drop, what happens? They'll not be able to walk on heels.
He is able to, sir, walking on heels.
Able to walk. Okay. Next.
This was the sensory examination.
Hmm.
So I've marked red. That is where there was loss of temperature. It was a cape-like distribution at the cervical level, but his pinprick touch and pain was normal, and vibration and joint position was also normal.
So actually, as I was telling you, the right side, you have to be more careful in examining. the sensation because of the possibility of brown sequoia type of picture which you presented in the motor.
Yes.
Skull is normal.
Skull, apart from the low line, hairline, posterior hairline, and in the
When
spine.
do you call it is a low-lying posterior hairline?
If at C5, at C5 level, if the hair line is there, then it is.
See, usually C1 and C2 are not bulbable. They are C4 and C5, right?
Yes.
So it may come up to C6 also, then you can say it is low.
Yes.
Below C6.
Yeah, anybody? Somebody saying?
Below C6, sir.
Below C6. That's what I'm saying. Below C6, you should say that.
Okay, sir.
Okay.
So other system examination was normal.
So no, don't go. Now,
okay.
you see, so now we have the investigations part. Okay.
Yes.
So what are you going to see? Investigations made. What are you expecting to see? I believe the routine hematological, biochemical, metabolic parameters are normal.
Yes, sir. Yes.
So main thing is on imaging.
Imaging, yes.
Right. So you're going to show the imaging.
Yes, sir.
Before that, anybody wants to ask any questions? Otherwise, you'll go to the imaging.
Sir, one thing, when there is only gait ataxia, no appendicular ataxia, how do we explain that?
See the lamination again of the posterior columns. The lamination is there
No,
for posterior
means
columns.
gait ataxia we are saying because of posterior column, because of cerebellum,
Yes.
sir.
No, this posterior column.
So
Not
can
cerebellum.
the gait be because of the spasticity in both the lower limbs? Because there was significant spasticity.
The spastic gait is not this gait.
It wasn't scissoring, but whether it was.
There is no scissoring. No, it's wide almost. It's going. It's trying to balance with a broad base slightly.
Yes.
Somebody said abdominal reflex is present, sir. Reason. So in a chronic, say, abdominal reflexes are multi-synaptic reflexes. So they are sometimes preserved in neurodegenerative disorders. But any compressive myelopathies, they disappear. Or peroneal tract lesions, they disappear. So here, possibility that the soft tissue element is not that severe. That's why abdominal reflexes are present here. Possibly. That's what I feel. And let's see what he's going to say.
Shall I show the imaging?
Yes.
This was the MRI whole spine screening that was done outside. So there was cord compression at the CV junction, and there was an enhancing signal at C1, C2 level. And
visible. Are you going to show more imaging?
So I have the CT films actually. We are suspecting CV junction. So this was the atlantoaxial instability that was noted. The patient had about 9.38 mm distance between atlas to dens. And so on drawing the Chamberlain's line, that is from the tip of hard palate to the.
This is a McGregor line. It is suboccipital line. No? From the hard palate.
No, this is to the foramen magnum, so opistheum.
Opistheum. So Chamberlain line is the suboccipital region, occipital. You are putting the line below the occiput, no?
So that is McGregor.
McGregor line.
Yes, sir.
Yes.
Yes.
And the dens is above that.
Yes, sir. He's ideally it should lie 3 mm below the line, but in his case it was 4 mm above. So basilar invagination was present, and we on drawing the Welcher's basal angle, it should ideally be less than 140 or 135. It is increased in platybasia. So he had an angle of 151. The Welcher's basal angle was drawn from the nasion to tuberculum and the tuberculum to the basion.
The clivus angle from clivus to spinal canal. That are you showing? Yeah. This is
the McGregor line.
Yeah.
So it was drawn from the posterior tip of hard palate to the lowest part of the occiput. And if odontoid tip is more than 3 mm above, then it is basilar vagination. This is 3.66. This is the Macrae line or the foramen magnum line. Also the measure of basion to opistheum. So the tip of odontoid is supposed to be 5 mm below the line. And other
Not
thing
only
is,
that, the diameter should be at least 9 millimeters.
yes, that
The
is
lower limit of normal.
yes,
Otherwise, spinal cord has to get compressed there.
compressed. Yes.
Hmm.
And this was the measure of basion to the ophistium.
Hmm.
So the tip of odontoid should be 5 millimeter below, but here it was just above.
Yes.
And another thing was he had this persistent ossicle terminal.
Hmm.
So the ossiculum terminal, it appears as a secondary ossification center of the dens, and usually normally fuses by 12 years, and it appears
Yes.
between 3 to 6 years. When there is failure of fusion, it results in persistent ossiculum terminal.
So he is 14 years, so it has not fused.
No, sir.
Hmm. So there is a cervical somites and the occipital somites. There are 4 of them. So dens is formed by both cranial as well as cervical somites. So that's embryologically these are joined by the time 12 years age happens. Okay.
So finally, we came to the diagnosis of a CV junction anomaly with atlantoaxial instability with basilar enagenation, platypasia, and persistent ossicle terminal.
Okay. Any surgeons are there on the anybody wants to, any radiologists who are attending? Anyone wants to say something about this case? It's a learning exercise for CV junction, a revision of that. Okay. I think today no teacher has come. I think Dr. From Delhi, somebody spoke, no? Is there? Dr. Bhavesh? Okay. Now you carry on.
So, sir, then the patient was subjected to foramen magnum decompression and C1, C2 decompression and posterior spinal fixation and fusion.
Oh.
This was his video on post-op day 1.
Okay.
And he came for follow-up after 2 weeks, and he has recovered. So gait is improving now, and otherwise sutures are removed, and he's doing well.
Very nice. So any questions, please fire, because we're already 1 hour. And if there are any questions, anyone wants to make any comments, please do that. So that otherwise we'll wind up.
Sir, good evening.
Good evening.
Yes, sir. Dr. Anup, sir.
Anup, bolo.
I have just entered and saw the case, sir.
Hmm.
Only one question, sir. Was foramen magnum decompression indicated, or was only C1, C2 fixation
No, the
adequate?
basilar imagination is there, no? Anup. I don't-
Sir, C1, C2 means what, according to Dr. Goel, he
Hmm.
thinks that only C1, C2 fixation and
Hmm.
putting spacers brings odontoid downwards, sir.
Okay.
And putting spacer in between C1 and C2. मतलब C1 के facet के नीचे अगर when we put spacer, it brings the odontoid downwards, and it reduces the height of it brings the odontoid downwards. So that causes adequate decompression, and foramen magnum decompression is not indicated.
Okay. I don't know.
Yeah,
Dr. Dr. Mandar, old days here, he would have answered, because I told him to be present for this case.
yes,
They operated, no? The
yes,
orthopedic spine surgeons.
okay.
I think your point, I think we have to discuss with the spine surgeon, Anup.
Yes, sir, yes, sir, yes.
But the case is very, well described by
But
Hari, and many people
we,
are.
yes, sir.
Anybody else? Okay, if there are no questions, then Hari, thank you very much for presenting a very nice case, and you took a lot of efforts in describing the radiological features and clinical features also, and you made good videos. So this case is going to be on YouTube. People can watch and learn later on also. And I think with this, if there are no comments, then I'll wind up this case. Anybody? Till we meet next couple of weeks later.
Sorry, sir, I got disconnected. There was no power in my place.
I had Dr. Bhupesh. Sorry,
Yeah.
anything you want to say? Because we have shown the radiology and all. You want to see again?
Yeah, that would be good. Yeah, please.
Yeah. Hari, just show the radiology.
Yes, sir. So this was the CT image. So here atlantoaxial instability. Measurement between atlas to dens was 9.38 mm. Chamberlain's line, there was basilar invagination. He was 4 mm above the line. Welter's basal angle was 151 degrees. So he had platybasia also. And McGregor line drawn from posterior tip of hard palate to lower part of occiput. Over here also there was basilar invagination. This is the Macquarie line, also showing the foramen magnum measurement of 6.6. And here the measure of basion to opistheon, where the tip of odontoid should be 5 mm below normally. Here it was just above. And also he had a persistent ossicle terminal. This is the arrow pointing it out. The ossiculum terminal appears as a secondary ossification center and usually fuses by 12 years. So he had failure of fusion, resulting in a persistent ossiculum terminal. So final diagnosis was CV junction anomaly with atlantoaxial instability, basilar invagination, platybasia, and persistent ossicle terminal.
So he's got both bony anomalies as well as soft tissue. I mean,
Right,
the spinal
right.
anomaly,
Right.
and only vascular it didn't compromise anywhere. Okay, Dr. Bhupesh, nice you attended and participated in the discussion. So we'll let you know when our next class is there. Thank you.
Definitely, sir.
Okay.
Will be an honor to join again.
Okay, bye then. Good night, everybody. I'll